All right, so good afternoon, everyone. Hope you're doing well and enjoying your Friday. I know a lot has been going on across the country, and if you're in Texas or Oklahoma in the heartland, we're praying for you and looking out for you and wishing you well. And also, if you need any resources, let us know. Any resource we couldn't get to you, please do. Um, and this is an important conversation as we move on into spending and funding and what needs to happen. We have with us, as always, Dr. Mia Keeys from the American Medical Association, always leads this discussion, and Melanian Igoren, Deputy Staff Director of the Health Subcommittee on the Committee on Ways and Means. And so we're kind of going to go through some questions and talk to Dr. Egorin about the COVID-19 package. I know a lot of folks have questions about the intent of the package, when am I going to get my check, whatever it is. We want to make sure we had somebody who's been working on it intently to answer these questions. But first, just want to make sure that we do one thing and surprise her, and it's her birthday this weekend. So Keiko, we want to wish you a happy birthday and thank you for all that you do. So happy birthday, Keiko. She didn't know I knew that or was going to do that, but but thank you for everything that you do. With that, I want to pass it on to Mia.
Oh my goodness, I love when there are things that take people aback. And so that was a beautiful offering, Brandon. I will echo happy early birthday, Keiko. All these Pisces in our midst here. You bring the good energy. Also just want to echo Brandon's words, extending thoughts and highest prayers to those who are in the heartland and those who might have family there. So remain safe and keep your head and your heart light and take care of one another. I'm also really excited that we are joined today by Dr. Melanian Igoren, who, as Brandon mentioned, is going to bring her perspective as really a veteran in health policy and specifically in the federal space. She's been with the federal government for over 15 years, and as the deputy staff director for the Health Subcommittee, she's seen it all across Ways and Means. And this is something that I'll bring up, Dr. Egorin, during our conversation. Ways and Means has just been so very formidable in leading the discussions in so many ways, not just around COVID specifically, but I mean with respect to equity and the fact that you all have held the first ever virtual congressional hearing during such a high time. That goes without saying just how historic that is. And I'm very proud on your behalf for all the work that you and your team has been doing. But then also you come to us with experience beyond the halls of Congress. I mean, having worked with the U.S. Government Accountability Office, GAO, and also being in academic spaces across the University of California, with San Francisco State University, and you yourself coming from an academic background in Atlanta at Emory University and also at UC San Fran. So I'm so excited for the perspectives you're able to bring today. And let's just go ahead and jump right into it. Tell us who you are, how you are. Well, first of all, tell us how you are. And then we'd love to know, just a bit more about what you're working on, and we'll go from there.
That's a wonderful question to start with, but I'm actually doing well. I am very lucky to be able to work from home, and I recognize that is a privilege. And I have set myself up with a desk that looks out over a very small park in Washington, D.C. on Capitol Hill, but I'm looking at snow, and it is, it's a little bit of happy when you're spending time thinking about things. Before we start, thank you for letting me join you on this Friday afternoon and do one of the things that I love doing, which is talking about the important work that Congress does. With that, I'm going to put out my disclosure that the comments that I'm going to make are my own. They do not necessarily reflect Chairman Neal, the Committee on Ways and Means, or the larger Democratic caucus. That gives me a little bit of freedom to be like, this is what I think. But at the same time, they're off the record and not for attribution. So if they're press, please don't do that. I used to joke a long time ago that I wanted them to let me leave the Longworth building, which if you've ever come to Washington, D.C. is one of the most beautiful buildings. And I have the privilege to work there. Now I just tell people I want them to let me back in because it is a true privilege to work for the American people and to work for Congress. So that's my disclosure. And with that, I can answer questions. And I will also tell you that if I can't answer a question, either because I don't know it or because for some reason I can't answer it, I will be honest and truthful about that. I won't play hide the ball or pivot and make you look over here, because that's kind of, it's not an honest conversation, and that's what I want to have. So
no, definitely appreciate the, you know, the willingness and the intentionality to come with the real, right? That's why I love these Friday conversations. And if you're ever able to tune into future conversations, you'll know that that is the cadence that we keep here. And it's part of the reason why this is my favorite part of my workday during the week, being with the NMQF family and also with our audience. So, you know, I don't want to make assumptions about what the audience doesn't know about the COVID-19 relief package. So I'm wondering if you can just give us an overview and we'll go from there.
Yes. So the COVID-19 package is a spending, it's actually kind of an interesting perspective, right? So it is using a quirky, totally inside baseball, Washington, D.C. budgetary procedure called reconciliation. And what reconciliation does is it allows a bill to move through the House and the Senate, and it doesn't require the normal Senate 2/3 majority to pass and to get through a filibuster. So that is the function of it. Now, what does that mean? That means that there are some limitations on what we can do, and that has shaped the policies that we put forward. First, you have to have a budget spending target, and that budget spending target for this package was $1.9 trillion, which sounds like a lot of money, unless you're talking about helping the economy in the middle of a health and economic crisis, right? And I think they're so intertwined. One of the things that has been fascinating for me, who's been doing public health for a very long time, is just how we're finally understanding, and you guys probably are all like, yeah, we knew this, because that's sort of how I felt, but we're finally understanding that health and economics are so linked, and the populations that are most at risk for suffering economic consequences because of a health crisis, right? It is not just because of health, right? It is the structural and underlying challenges within and inequities within our society and within the way it is constructed. Okay, so that's the framework. We have this weird budgetary thing that we're doing to try to fix the world. And with that, we did some pretty amazing things in the health space. We were able to increase the FMAP, the federal match for Medicaid, to help expansion states, as well as to help folks currently providing Medicaid and a Medicaid match. That's the Energy and Commerce Committee. That's about what I know about it. I know that it's good, right? It gets people coverage, and I'm all about the and, right? Medicaid and the Affordable Care Act. So in the Affordable Care Act, we're building on doing two things that are really important. The first, in the first time in 10 years, we're actually doing an improvement to the ACA. That is taking Representative Underwood's bill to make advanced premium tax credits more generous for those who already receive the tax credits, but also lifting a cap at 400% of the federal poverty level and letting more people have access to this important financial assistance for health coverage. So that will be for 2 years, the current year and next year, with the hopes, fingers crossed, toes crossed, everything, lots of rabbit's feet being rubbed, whatever your thing is, just keep doing that we can make it permanent in the future. But this is a really good, strong down payment for the next 2 years. The other policy in the ACA space is allowing individuals who receive unemployment compensation, so UI, to get a potentially more generous subsidy for 1 year, similar to what COBRA does for larger businesses, right? So COBRA provides, economic stability and financial assistance and that knowing of health insurance for workers who had employer-covered insurance and worked for larger firms. But if we look at who's been hit by the economic consequences of COVID and who is suffering job loss, I mean, the numbers in December broke my heart. They were almost exclusively women and predominantly women of color. And that's because of the sectors that have been hurt the most. It is food service, it is retail, it is small businesses, it is entertainment. And so many of those jobs either don't come with employer-sponsored insurance or aren't for an employer large enough to have COBRA coverage, or the business just closed because after trying to hold on for 9 months is no longer, can't keep the doors open. So COBRA isn't an option. So we're providing for 2021 advanced premium tax credits at a stable level for individuals who are receiving unemployment compensation. Under the normal rules of advanced premium tax credits, and we can get wonky if people have questions, but it's like, I'm super excited by this because I think it really looks at what's happening in COVID and says, there are communities that are disproportionately affected, and how can we use what currently is there to act as that bridge, right? To make sure that people have health and economic security and don't, it's almost the reverse of job lock, right? Can feel like they can go and kind of continue and look for the right employment and do what is right for their families during this time. The third policy, fourth policy, if you count Medicaid, is COBRA, which I alluded to for large employers. And we actually provide a subsidy for COBRA at 85% of the premium, which is higher than what most employers pay. And that's really important for populations that are to continue care and have that consistency. So as I said, I'm excited because we've been talking about ORs for so long. Is it Medicaid or the ACA or employer-sponsored insurance? Right now, it's the and. It is any way we can get people covered. We can help people with their affordability, which is also so important right now, and make it as meaningful as possible. So that's the COVID package.
You dropped so many jewels there, and I'm finding myself wanting to pick out certain things that you said and reiterated, for the audience, So, I mean, we're both academicians in a lot of ways, and so are a number of people in the audience, and so we'd be able to appreciate the fact that, dating back to the early 90s, we've had researchers, particularly Lincoln Phelan, in their 1995 study around what the fundamental cause of ill health is, or the fundamental cause of wellness, really does go back to socioeconomic status. It is an economic argument. We can have conversations about individual responsibility, and risk and behavior and such like that. But it really just does come down to your point, one's space of economic security and the way that bears on health, right? And so I really appreciate you picking that out, especially because too, across the aisle and even within the Democratic Party as well as within the Republican Party, there are people who will argue, well, investments in more equitable packages or policies have such a high economic price tag, right, that it's almost not worth investing in. But clearly, as you mentioned, COVID just completely underscores the fact that we've neglected investments, economic investments, for so very long in our healthcare infrastructure and our public health infrastructure, that we're doing ourselves a disservice if we do not evaluate the economic impact of such a dire public health threat. Yeah.
Sorry. Okay, wait. So this is my favorite part of COVID. I'm going to now share your audience can be like, hi, hi.
Hello there.
Hello.
Very nice.
My favorite part of COVID as a working mother is you always felt like you had to have that dichotomy and you had to hide this. Not that I don't want to hide this because she's amazing. But right, but you always felt like you couldn't share that. And it has opened up and removed. And I think it has been a burden in some ways for lots of working parents, but it has also shown what life looks like for folks. And whether that's your children or your dog or your roommate or your parents or the fact that you've not moved because you live in a studio apartment and you've been staying there. It's that you started out, you asked how I was, right? Like, I like that we have become people that see each other in a slightly different way than just like our black suit, I can be a grown-up office view. So
this is absolutely the truth. And what you all don't see is that I have on fuzzy moccasins right now. And this is my parts of my personal investment. And I will have a hard time, if I have to go back to the office and have to put back on my heels, which I also love, right? But the other thing,
she said she missed her heels.
I know you went to, and then
you miss your heels.
There are about like 75 people paying attention to you hugging me, but I love that you came to me.
I love it.
I know you're wearing my Uggs. Okay, go back.
I love it too. Thank you so very much for joining us. But and that also brings me to the point that you also made about matriarchs, and those who who are so very impacted by this time, right? And not just parents who are mothers, but we are seeing, to your point, the impact, and inequitably so, on parent-run households that are matriarchal, right? And it's
that impact. It's the intergenerational experience, right? Like, how does that fit together? How do our normal constructions of fact? This is the sociology part. This is the part that like makes me. This is the part I like talking about, right? Like, we have these social constructions of family. We rely on them. We think about. I mean, and how has this forced that shift, and how has it made it harder? To your point on.
And how then do policymakers consider it in policy design? Right, in a very different way. You know, when I think about some milestone health policies in terms of, I mean, we can run through. I mean, we're talking about building on the ACA here, right? So that's one milestone policy. We can take it back and talk about ideas around welfare reform, which were certainly conversations generated around the gender construct, and specifically the female gender construct. We can talk about the we can talk about the Americans with Disabilities Act, right, which centers people with disabilities, but it also has a valence on there with respect to age, to gender, to race, right, and certainly socioeconomic status. All of our major health policies, Medicare, Medicaid, everything, right? When we talk about design of policy, we can't be absent any longer or whisper words like women or, or all of that.
You guys want to hear right. And we tend to talk about, so this was not where this conversation is going to go.
I promise you we're going to go back to the
Mia, I would love to have this conversation because to your point, we talk about Medicaid and we talk about Medicare, but we don't talk about them as Medicaid we talk about as a women's health program when we talk about women and sort of childbirth, right? But we don't talk about Medicare and Medicaid in terms of women's health programs for older women, right?
Yeah.
Like in our aging society, Medicare and Medicaid are still disproportionately programs that provide services to women, not of reproductive age, but like that there's a whole constellation of caregiving, of delayed care, of just how we experience healthcare okay.
And for people with disabilities,
and for
many of whom are women, yeah.
But it's I spend a lot of time where everybody's like, you don't do women's health. I'm like, Medicare is a women's health program. It is an important women's health program. It's just a part that we don't talk about. And so we
don't talk about it because we also just don't always have access to platforms like these that help to break it down in that way and look at it. We've got to be, and this is why I really, COVID is a horrendous thing. But what it has forced people to do is think about and build a consciousness around, these conversations we've not had before, right? Around, how does this overarching pandemic, which hits all of us, how does it, break it? How does it interact at our intersections, right? And what does that mean in terms of access to the benefits of the packages and the policies that are born of this, this tragedy. And then also, how does it encourage policy design from a more equitable standpoint moving forward, which is a question I'll probably give to you in a whole nother way later on. Yeah. But I'm wondering, Dr. Igoren, if you can talk to us a little bit about, so you broke down what's in the package, what's being teased out right now in the package through the reconciliation process. Can you talk to us a little bit about funding, particularly for testing and how we need to think about that from like an equitable standpoint? Like, how focused is the relief package on funding for improving and making more accessible COVID testing as well as vaccines?
So there is an investment in both testing, and there's been a consistent investment in testing since we passed the first COVID package 11 and a half months ago. And from the beginning, we have fought very hard to make sure that it is no cost, that it is covered, that there is. Now, we saw the challenges of our public health system. We saw, the fragmented nature and discordant nature of the public health system has definitely been on full display for everybody, but we've tried to fill in gaps, recognizing their problems. this package focuses on both testing as well as vaccination. And I'm going to say this is where I'm going to stop, and I will share information because this is in the energy and commerce section, and I don't want to get it wrong. So I will send Brandon and Kiko the information that I have on it so that they can distribute it so that the right information gets sent to the right people, if that is okay. But we as the House, you've seen Energy and Commerce and other committees really focus on looking at vaccination, not just what is the pipeline of getting a vaccine, but distribution. What are the conversations of making sure that it gets to communities in a way that is culturally appropriate, right? And that meets the needs. I think that that is a challenge. And to make sure that this is me, Melanie Igoren, right? Like my frustration is that my frustration is that the points where we choose what is easy as a public health community, because there's that value of like what is easy and gets the most number of people, whatever it is. Whether that is vaccinations when we're talking about COVID, whether that is education about, disease prevention. And sometimes it's the harder stuff that we don't do because it is this sort of whole society view, but that harder stuff is what we have to do, right? There's conversations, the figuring out how do you get vaccine acceptance? How do you get vaccine distribution? I think West Virginia, I can't believe I'm saying West Virginia has done a beautiful job. Words I never would have expected to say in the public health space. But West Virginia was like, we can't use large pharmacies. We don't have coverage. We want to use our community pharmacists. We want to use the community where that person knows somebody's medication history. They see them, they know they are that center for healthcare in a way, especially for communities where there aren't big hospitals, where there aren't the resources that so many policymakers think, and they're just like, oh, it's fine. Everybody has a Walgreens around the corner. And you're like, no, right? I mean, I live in Washington, D.C. I live less than a quarter mile from the Anacostia River. And the difference of access, depending on which side of even the Anacostia you're on, to those large pharmacies will make a huge difference in access. So as policymakers, we need to continue to sort of push and ask those questions.
I really appreciate everything that you just offered, but then specifically, I want to pull out the geographic considerations that you've just mentioned. I think we're getting a lot better in the policy spaces, unpacking issues around race and gender, and that does not by any means mean that lawmakers are very good at that just yet. But I think when we're talking about meeting issues that work pretty well between Democrats and Republicans, they tend to do much better when you talk about like rural access to medications, right? So I'm wondering if you can build on that a little bit, especially because Ways and Means has the Rural Health Task Force and such like that.
So it's not, to your point, it's not just the rural task force, right? It's the rural and underserved communities task force, yep. Because they're always, I mean, you're completely right, Mia. We always talk about the rural issues and access in rural spaces. And the more we heard those conversations and really thought about what as staff we knew about healthcare, we're like, wait, no, two sides of the same coin, right? It's rural and underserved. The access issues and the solutions are often very similar. So the chairman of the Ways and Means Committee 2 years ago established the Rural and Underserved Task Force. It's bipartisan. It is done some pretty amazing work for a congressional committee. And most of you out there probably are like, this is what normal academics do, or this is what people do. Congress doesn't do what this task force did, which was put out an RFI asking for best practices, writing papers that showed what were those best practices in a bipartisan manner, as well as reports that came just from the Democratic side, really bringing forth conversations around health equity. And it's an incredibly robust conversation that has led to some really interesting other side conversations in health equity, including a recently released framework on equity issues across the Ways and Means jurisdiction. So Ways and Means does health, mostly Medicare, but tax, trade, Social Security, human resources, so things like TANF and unemployment compensation. I think that's what we do a lot. We touch lots of the economy, but putting out an equity framework that says we're going to look at our policies from that perspective. Sorry, you could see all parts of my family. Right, so there's this framework for how we're approaching things. And that came after 2 years of Chairman Neal, when we were in the majority, having a very deliberate conversation about this. So Mia pointed, we had the first virtual hearing. My bigger moment of pride was we had one of the first hearings on maternal mortality in the Democratic majority, and it was amazing. It was amazing for several things. One, it was amazing because somebody used the word systematic racism in 1100 Longworth, which is this august room. It's the backup house floor. It is breathtaking to walk into, but before it was something that was sort of part of a national conversation. Well, it had been conversations in various spheres, but before it really had come to a national fore, they were like, no, this is a symbol and this is a result of what happens through structural barriers and specifically structural racism. It was
I remember that.
It was also the first hearing where, in a very deliberative manner, we had 2 nursing mothers on the panel, and we took a break. And everybody's like, "Oh, did you take a break for lunch?" We're like, "No, we took a break because our witnesses at our hearing had health needs that needed to be addressed, and we were having a conversation." Like, we didn't make a big deal about it, but it shows how being thoughtful and really honest with the conversation makes big, scary, stuck institutions slowly shift. And it makes it so that panels can have new mothers there. We've subsequently had panels with people with disabilities that required care needs that needed breaks and attending care. You have to make those choices to do the hard thing, to make it so that it isn't just the way we always did it with a bunch of people that didn't need to go take breaks or didn't need accommodations. Like, that isn't going to bring the voices to the room. So Chairman Neal, and I got to say, a lot of it was the spirit of John Lewis, who was a member of the committee, being like, we need representation matters. And he always said, you need to have the diversity of the voices of the American people there and before us, and being able to do that in the majority. So we had a number of hearings before we went virtual on issues that were important then and have come even more to the fore. So one on maternal mortality, one on gun violence, one on climate change and the health implications and the economic implications. Since COVID, we've talked about different workforce issues. We've talked about women needing to return to work. We've talked about the importance of sick and paid leave. I mean, I don't know, and all of that fed into this sort of culminating document that my colleague Ariel Richardson worked on from the staff perspective, but that came out, and it was a committee product with consensus and a vision that is really wonderful.
And historic. We had Ariel on some months ago for one of the conversations, and we were very grateful that she was able to at the time, it was prior to the release of the document that you mentioned, and she alluded to it.
Probably never would mention it because that's how we're trained as congressional staff. We're trained, you never take and celebrate any of your victories, right? So it's my job to be like, this is important work, and it is important work that we all did, but there was a leadership role from a staff perspective. It goes right.
And you see the shift again in the ways then that the policies are more thoughtfully designed. I remember that day specifically of the maternal health hearing, because at the time I was still working for Congresswoman Kelly, and the then president of the American Medical Association, the first African-American woman, Dr. Patrice Harris. Dr. Harris was also giving testimony that day, and Miss Kelly was invited to also give testimony, even though she wasn't on Ways and Means. And there I was with my then boss, looking at what I didn't know eventually was going to be my new boss under Dr. Harris. and thinking about, and looking at all these other people who were on the panel and thinking about just not truly understanding, but certainly appreciating how that hearing was certainly going to bear on future policy, and not knowing that we were walking into a pandemic. And so when I think about some of the other things that you've mentioned with respect to, I mean, you live on the other side of the Anacostia River. I know that when you're talking about people needing access not just to pharmacies, but also to hospitals and to clinics, if we were to bring that back and think about the COVID-19 bill, like I'm wondering, does the bill, could you share with us the extent to which the bill mentions clinic and community health workers, or people who a lot of communities may not necessarily have access to, but we certainly need them.
Yeah, and I'm going to say that this is an area that I am.
It's a DNC.
Both the DNC, and I'm actually embarrassed to say that I did not pay enough attention to, because it is so important. Prior bills invest a lot in different types of providers through the Provider Relief Fund, through various other things. But this, I will say, I did not do my homework before coming here, but I will share back that information, because it is important.
Yes, absolutely. And then I am unmuted. Okay, I thought I pressed my unmute twice to mute myself. So you gave us a really significant breakdown about what policies are being presented through the bill. Do you have a firm idea about what you think will go into the final iteration of the bill, or won't, or where are your thoughts?
My hope is that it all goes there. So the next step on this weird process is that it goes to the Senate, and the Senate, my Senate counterparts in the Senate, have discussions with the Senate parliamentarian. And they do something called describing the Byrd process. So Senator Byrd, when this sort of reconciliation process was established, said everything had to be have a budgetary impact. And so they have to go and basically debate, is that a budgetary impact, or is that just a policy thing? And I'm like, but they're all right? They all cost money, but it's a fundamental, and it is a value judgment of the parliamentarian. So I think that's the next step. I am hopeful, fingers crossed, toes crossed, again, that the parliamentarian sees this coverage as being policy, or seeing it as budgetary, not policy, but that's the next step. And the perfect example of what people do to change this, right now there's a lawsuit before the Supreme Court, California v. Texas. It's about the ACA, and it's about the individual mandate. The parliamentarian, during reconciliation, when they were doing the tax bill and they were repealing the individual mandate, said you can't repeal the individual mandate, that's policy, but you can zero out.
Right.
That's budgetary. Right. So they zeroed out the penalty. And so the question now is it a tax?
Is it constitutional?
Is it constitutional? Right. But that is a result of that back and forth. And it's kind of, that's the next part of the dance.
Well, we hope that is a dance that doesn't step on your toes. Or
I think not.
So I know that we've about 5 minutes or so. Another question that's been presented has to do with health, with community health, right, and the pandemic. So the NMQF has been hosting a number of conversations around vaccines and such like that. So the question is, what's the main reason that the health community during the pandemic isn't utilizing available treatments like antibodies to treat COVID-19? Now, this is also, NMQF a couple of weeks ago hosted a conversation around therapeutics in addition to vaccines. And I know that this is a wonky immunologist related question or virologist related question, but yeah, if you have anything to say about that, I certainly open the floor for that.
So I actually don't know the answer to that. I'm not a clinician. The last time I spent time in a clinic or even in patient care was when I was in grad school. But so I don't know. But I think it's an important question, right? I mean, I think it's one of the, I will say, I think it has more to do with how we approach medicine, right? Like there's only one answer. There's only one way of, this is the best, right? So, or this is X and this is the clinical standards. And so we don't think about the panoply that may be out there for treatment. But I don't have a better answer. Or
no, I think you hit the nail on the head with that. It's, we don't necessarily have the plan yet in that way.
Right.
Yeah. Yeah, I'm wondering, oh, so someone is asking if you can repeat the name of the bill. And we will link to the bill number in congress.gov in the chat.
Yeah. So it doesn't yet have a bill number because
not yet.
No, not yet. So you can go to the Ways and Means website and look at because it's right, because it's this weird thing. It isn't individual bills. It is all of the bills pulled together. So Ways and Means has a title. The tax stuff was under subtitle G. The COBRA stuff was under subtitle F. That doesn't really mean anything. If you want to read the advanced premium tax credit bill, it is, that is Miss Underwood's bill, and it's HR 369 is the basic framework for it. The payment levels are slightly different in what will go to the House floor, but it is the general concept. We actually were able to find more money and make the tax credits more generous. I'm all about that.
I'm all about that too.
They were like, you have more money. You're like, I will change this dial. Like, yes.
So do you want to give the audience a bit backroom insight into what that negotiation process looks like, what it feels like how does that work? You all are working across, not just bicamerally and across party lines, but across committees as well, you know? What does navigating all of that to get to a final product look and feel like? Mm-hmm.
Oh. So first is, I mean, well, everybody wants things to, I always joke, people want to like introduce an idea on January 15th and have it become law on March 15th.
Right.
What it should be is an idea is introduced January 15th in 2015. It might become law in March 15th, 2021.
Mm-hmm.
And I actually think the tax credits are the perfect example of that. There's a long socialization period. It starts with, I have an idea, or I have a problem, or we have built the perfect mousetrap, the ACA, and then it gets implemented and you see what happens and you see that some of the decisions that were made 3 years beforehand didn't quite come to fruition in the way you had planned, or policymakers had planned. I wasn't there. So in doing that, people present ideas, and then there's a socialization and a conversation about it. There's the knowledge of policy experts. We often turn to people beyond Capitol Hill and ask them all kinds of questions about what have you seen, what exists in the insurance space, what happens in Medicare, what happens in Medicaid, what happens in the employer market. And you talk about it and everybody does their homework. I mean, I'm always in grad school. I love it. So you do your homework and then you talk. There's a process of coming up with a legislative idea. We actually are blessed to have legislative counsel, which are the unsung heroes of the US Congress. They are these very smart lawyers who are very specialized in their knowledge and will write the legislative text that one of my fellows just described it as, she's like, I have no idea what I'm reading. I'm like, you'll learn it. It's a foreign language, but it's right how we do things. And then we actually seek the advice. It's called technical assistance of the agencies that we will ask to implement this, because what you do not want to do is draft something that is brilliant policy. And then they're like, one, there's a mistake, the functional equivalent of a typo. And then you're like, well, and they're like, we can't do that. You're like, oh, that's embarrassing. Or two, you have this great idea and they're like, but it will take 2 years to implement. Or have you thought about, there's this requirement that nobody may have known about, but there's a data sharing issue, right? That for getting people health insurance, we can't have the Department of Labor talk to HHS because of the importance of protecting people's data and confidentiality. So if you can't have this talk to this, like how do you work around it? What do you do? And it's an iterative, for me, is like probably having flashbacks to doing this, right? It's an iterative process. And then you have a proposal. I work really closely with my colleagues on the other health committees, which are Energy and Commerce and Education and Labor, as well as my colleagues on the Senate side and Senate Health and Senate Finance. All the while, right, we are the staff, we are doing this. The members also have, like, they are the ones with the certificates of election. They are the people that have to agree with the policy. That is one of the reasons that once you do this sort of staff work, the bills come to a markup before the committee, which is what, if you want to watch 3 days of really fun procedural debate, you can watch it on the website Brandon just shared. But there's a public discussion of the policy. The policy is read. There are experts, depending on the committee, it depends who sits there, who explain the policy. There's the chance to amend it. There's the chance to ask questions and clarify about it. I think that's an incredibly valuable part of the process because members do, like, they have to vote on this. They have to be able to explain it. And a lot of times the idea is that when I was talking back, January 15th, here's the problem. Those come from members talking to constituents. Those come from members thinking really carefully and very strategically about what they are seeing and what they are hearing and what they're hearing from their colleagues, what they're hearing from their constituents, what they're reading in constituent mail. Those are my favorite projects to work on. And when somebody comes and they're like, explain to me why this is happening. And I'm like, I don't know, let me do my homework. And the member is like, this should not happen. How do we fix it? And sometimes those are really, really big fixes. The ACA. Sometimes those are really small but super important fixes because nobody thought about the person that was going to get a lump sum Social Security disability check and all of a sudden no longer be eligible for their advanced premium tax credits. Or no one thought about what happens in families that don't look like the traditional family and how does that fit together in insurance. This is one of my, like, not everybody, policymakers, it's easy to do things for the most simple case. It's the complex case. It's the family where there are two parents with different health insurance, each from their own employer, and the kids are on CHIP. Well, how do you make sure that they have the care that they need and they have the coordination and that there aren't rules that butt up against it that make healthcare less affordable for them? That's a much harder case to solve than the, like, family of 4 covered by employer sponsored insurance until the kid's 26 and gets their own job, right? Like, that's a relatively easy model. It's the complexity that makes it fun. And those often do come from letters and calls that caseworkers in individual offices have. And that's the fun part. Okay, so you've done all this, then you have these conversations, and sometimes they are bipartisan, and that is wonderful. I think the Support Act, which we passed 3 years ago in the middle of, or the height of the opioid epidemic. I can't even say it was the middle. I think we're still in the middle, but during a period of time where there was the gestalt to work on that issue, it was so incredibly rewarding because nobody ever talks about the bipartisanship, right? It isn't fun. The news has much more time, like, blowing stuff up. And in the middle of that, they were trying to repeal the ACA, right? Like, we were repealing the ACA in my morning, and in my afternoon, we were sitting in bipartisan meetings talking about how to make sure that we could expand medication-assisted therapy for people in Medicare, because that wasn't a benefit covered under Medicare, despite the fact that overdose hospitalizations were predominantly people over 65 in 13 states in the country at the time. Medicare didn't offer Matt. Why not? How do we fix that? So my days were bifurcated. It was fun. But nobody, like, that's right. That doesn't make splashy news to be like, a bunch of members want to work bipartisanly to solve problems, but that's what members do. And as staff, we get to do on behalf of them with our counterparts.
Your face lights up when you talk about bipartisan policy design, and rapport building. And that is literally the essence of democracy, which I think, with COVID, we see sparks of that, right? We see teams of members and their staff committing to coming to a consensus, right? and preserving the integrity of the intention of democracy, which is, toward wellness and representation and such like that. But then there are other elements of COVID in particular that are clearly split along political lines, and you mentioned the bifurcation of your days. Are you feeling that more acutely these days? Is it a different tenor? How does that translate in terms of working around vaccination issues and then COVID more broadly?
So it has been very hard to, COVID's been fascinating to me from a position of like, how did good public health measures become politicized? And how did the idea of taking care of yourself, but also taking care of your neighbor, taking care of your community become politicized? So that tone and tenor is different. I think that it has been hard, and this is sort of a national conversation, right? It has been hard to understand that COVID has affected everyone and has changed the way that people interact with each other, interact with their communities, interact with the world. But there's still a hesitancy and still an otheringness that just drives me honestly freaking crazy. People being like, oh, that's only New York, right? When the pandemic started. Oh, that's only New York. Oh, it's only in inner cities. Oh, it's only in jails and nursing homes and large congregant settings. And you're like, and that's very easy to dismiss because of there's already marginalized populations. There's already those points of discomfort to talk about. And then it becomes, oh, wait, maybe it isn't. But like, we've had all of these conversations around nursing homes and around safety. We never had a comparable national conversation about Sturgis and all of the cases that could be traced back to Sturgis. And I think that's just, that part is the part that's hard. My Republican colleagues are, and if you watch the markup, you see this, like they understand this issue. And we did a ton of bipartisan work in the CARES Act. There's also different views of what is the role of government. And part of doing bipartisan work is knowing that, right? The people that work for Republican members, for the most part, and I will say there's definitely pockets where I'm not sure they would agree with me, believe government should work on behalf of the American people. That was definitely tested last month, but I'm going to still believe that most people believe that work in Congress, that Congress and the federal government works on behalf of the American people to make it a better society. How you do that is very different depending on your political sort of orientation. But if you start at that place, it's a lot easier to find those points of commonality. Right? My solution to getting vaccines out will look different than sort of a Republican thing, but we do know that vaccination needs to happen. And then there are other points where you just know it. I keep saying, you just know it's the trigger word and you go, okay, that's entered the meeting. We all need to step away. We'll come back.
You said something earlier that I'm rethinking about it. But now I have multiple thoughts in my head in our last couple of minutes. You were talking about really the investments, where the lack of investments tend to show up, and they tend to show up in crisis moments, right? And in this way, in terms of the broader consciousness of like the American conversation around COVID-19, what is very apparent to me is that on a STEM level, we are challenged nationally with understanding, or at least remembering from biology class, how a virus works, right? How contagion manifests, right? What an infectious disease does and is, right? And the models around infection. So we are challenged in terms of STEM education, and the pandemic has shown us that. In a similar way, we're challenged in terms of our civics and understanding how our government works, right? And to your point about the way that, depending on our political leanings, our definitions of democracy might change, our definitions around the role of government in bringing us out of a pandemic might change. Where are you seeing, beyond public health structure, beyond science investments and such like that, where else during COVID, after COVID, do we need to be focusing appropriations and supports and investments so that people are not duped by things that they shouldn't be duped by because they don't know how X, Y, and Z work in science and education, so on and so forth?
Yeah. I think an investment in science is important. As you gave my bio, right, I am a product of a large academic medical center where like all we did was science. Science is important. I think what's interesting about the time of COVID, and this is maybe a little bit more of a historical perspective, is that during periods of pandemic, whether it's COVID, whether it was the flu in 1918, whether it was the Black Death and the plague, what we are seeing around disbelief in science, sort of believing in experience more than collective knowledge, the willingness to sort of follow those trails. I mean, that is a historical, almost human experience. So I believe in education. I think that we have to go back to being like, science is important and here's how we do it. But I think there's still something fraught in the human experience around uncertainty and disease that no matter how much you know, that is still there, regardless of the time period.
I'm with you on that. And I also think what you mentioned earlier about knowing people's inner worlds, right? There's a practice of empathy that we won't necessarily get from schools, right? And especially the way that science is taught, it's taught with a valence of objectivity, right? But the fact that we're all together in this all-consuming, horrendous episode in our nation's history, we're learning by force that togetherness while we are separated is significant, right? And that's not anything you'll get in a classroom. But for me, it's the and, similar to how earlier you were saying that it's not just you were talking about Medicaid. It's not just Medicaid where we need to, or Medicare or Medicaid where we need to look at things. It's not just the ACA. It's the and. So I think that and juncture is where we need to be moving forward with respect to all of our investments. And we can't wait until something becomes a tragedy to focus on it. Yeah. I in these last couple of minutes here, Melanie, I want to know if you have any closing words for our audience.
No, I want to thank you for letting me spend time with you and getting to talk about apparently the thing that makes my face light up on my snowy day. No, I want to thank you. I want to thank wanting to know what happens at the staff level, wanting to look a little bit under the hood of Congress and understand that there are lots of dedicated people that work there, and the members and the staff and the stakeholders who are many of you are probably who come and talk to us and share those ideas. Like, please keep doing that, because that's what makes the process better. So I'm very happy to end on that.
Well, I'm very happy that you joined us today, and I certainly got to geek out about some things. And this is why this day, this part of Fridays is my favorite part of the workday. I just have an excuse to be the big nerd that I am. So thank you so very much, Dr. Melanian Igoren, who joins us as the Deputy Staff Director of the Health Subcommittee on Committee for Ways and Means. I'm going to turn it over to Brandon Garrett to give us any final words. UF. Brandon, you are muted, sir.
Got it. And I think I do that every week. So I'll get better eventually. But just want to say thank you guys for all. Thank you both for just sort of have my policy walks on today. Just sort of educating us not only about the process, but the things that are in the bill most relevant. And then I'm looking for Dr. Egorin we'll just follow up on a few things that I know folks may have a little more questions on. Just want to end it in this very, very positive way. And I hope you all have a good weekend, but I hope none of us have as good a weekend as Keiko does. So happy birthday, Keiko. Everyone have a great day.
Happy birthday. Stay safe, everybody. Thank you for the encouragement, folks. See ya.